put that in our Zoom, ma'am.
Okay, da.
Okay, ma'am. Let's start, ma'am. Good afternoon, everyone. It is with the immense pleasure that we welcome Dr. Rajkohila, ma'am, to the today's anatomy crash course session on the topic high yielding topics in upper limb. Dr. Rajkohila, ma'am, is a distinguished faculty member from Department of Anatomy, Madurai Medical College, and is associated currently with DigiNow, where she continues to inspire the students with her expertise and passion for medical education. With the years of teaching and in-depth knowledge in anatomy, Dr. Raj Kohila ma'am is known for her unique ability to simplify complex topics, making the learning experience most enjoyable and effective. Her dedication to the cause of medical education has left a profound impact on countless students across the country, including me. When we started Medusane in 2020, from that day to today, she is continuously supporting us not just by providing the lectures, but also for the students, those who are part of our forum, with the examination, motivation, guidance, and whatnot. We are very thrilled to have her here with us today after nearly 1 year after she got associated with Diginow. And today it's a very interesting topic. High yielding topics in upper limb is going to be precisely discussed. This session promises to be a valuable opportunity for all the students aiming to excel their exams and strengthen their foundational knowledge. Let's extend a warm welcome to Dr. Raj Kohila ma'am on behalf of Team Medusane and express my gratitude for her continued commitment to foster the medical education. Over to you, ma'am.
Thanks a lot, Raghu. I like Dr. Raghu, I know, has a busy schedule and he had taken his time to give me this lengthy intro. Medicine has been close to my heart for the past 3, 4 years. Okay. Guys, a very good afternoon to one and all. And since most of you are having your upper limb internal assessment in a very quick date, we thought we'll have a quick revision of upper limb covering the high yield topics. And then whether to do it as an essay or short note, I preferred MCQ discussion so that it'll be more interactive and we can cover a lot of topics in a short duration. All right. So almost all set for your upper limb internals examination. And I'm sure each one of you must be having the most important topics, high yield topics in upper limb, isn't it? And yeah, finish your first or second revision. So the one that has been given here in this slide is the important questions, essays very frequently asked for your upper limb internal assessment. But with the change of the question pattern now, you can imagine all this in the form of a clinical scenario, isn't it? So everything, mammary gland and shoulder joint, you will not have a much difficulty to identify the clinical scenario. Right, mammary gland mostly relating to malignancy and shoulder joint dislocation, right? Brachial plexus injuries, axillary artery could be a direct question. What about the nerves? The clinical scenarios related to these three major nerves, right? You have to pick out the clue from the case scenario given. They are not going to directly give you the radial nerve injury, median nerve injury, or ulnar nerve injury. But definitely there will be a clue hidden in the case scenario, right? So I'm sure you have to be very thorough in these important topics, right? Essay question and to figure out the case scenario behind this. Coming to the list of short notes, yes, so many important short notes are there in upper limb. And remember, your short note presentation is very important. Do not try to finish a short note within one page in your test note. Okay, so make sure you have a diagram, you end it with the applied anatomy. Okay, so also all the muscles in upper limb, definitely you should be prepared for a short note. Deltoid, pectoralis major, supinator, biceps brachii, flexor digitorum profundus, the intrinsic muscles of hand, thenar muscles, right? All of them are very frequently asked short notes. And clinical anatomy, very important, right? So this is the list actually given to me by a student from our dissection table, and I think it covers all the high yield topics. Okay, so I hope this is your second internal assessment for most of you after finishing your lower limb. So lower limb itself, you must have understood what is a mistake you have made. and you should take effort to not to repeat it in your upper limb internal assessment, isn't it? For you, it is just one note that you're going to submit, right? But imagine the faculty you must definitely been to your faculty room, your table tutor room, and their desk piled up with all the records and the test note, right? So depending upon the strength of the students and the proportionate faculty in each institution, okay, each faculty can get to have around 30, 25, 30, even 40 notes to correct, isn't it? So imagine a faculty correcting 40 test notes, and just that few pages, you can either impress or irritate the person who's correcting your test note. Presentation is extremely important. Though you don't impress the person correcting your test note, you should be very careful not to irritate them, right? So that shouldn't pull your marks down. Presentation is extremely important. Yes. And time management. So it's going to be either essay question. Now the university pattern, Tamil Nadu MGR university pattern, right? It's been modified to 10 mark, and then you have a short note, 5 mark question, and reasoning out all that. So how long do you think can you write for a 10-mark question? Yes, you can take a maximum of 30 to 40 minutes, and definitely not more than 40 minutes. Okay, so how much ever very good you write. For 10 marks, we can give you a maximum of 8. Okay, so try to cut short of time. Make sure you finish your essay before 40 minutes. And each 5 mark, yes, you can spare 8 to 10 minutes, and make sure you attend all the questions. Don't leave your pages empty. Don't leave questions unattended. Handwriting is, of course, very important, right? Don't leave your examiner search for content, okay? Your handwriting should be very legible, clear. The concept should be made very clear. So we'll start with today's session with all the MCQ format as I told you, right? Covering all the high yield topics in upper limb. Of course, MCQs, when you go through, you'll find that most of the options, option A, option B, option C, and D, they are very close together most of the time. And sometimes the answer can be very hideous also, isn't it? So do not make a haste to complete your MCQ. It can definitely boost your marks up, also pull it down. To start with a very easy question, action of the pointed structure include. So what is this pointed structure? You can keep answering in your comment box, right? Okay. So we want to make this session interactive. The pointed structure is a muscle over the pectoral region. What is it? The pectoralis major. Very good. So they've asked you the action of pectoralis major. Remember, in your spotter examination, they're going to pin a muscle. Definitely, they're going to ask you its nerve supply and action. Okay. When you get it as a theory question, you have to talk about its attachments. So what is the action of pectoralis major? What is the best option right given here? Okay. So it is going to cause adduction and medial rotation. The pectoralis major muscle that you see here, it arises from, of course, from the clavicle, from the sternum, from the costal cartilages, and the bilaminar twisted tendon. Where does it go for insertion? Into the lateral lip of the bicipital groove, isn't it? And the medial lip of the bicipital groove, can you tell me what is the insertion? Teres major. And in the floor, yes, latissimus dorsi. What is the nerve supplied to pectoralis major muscle? Both medial and lateral pectoral nerve. So this was a recent NEET PG question, a cadaveric specimen with the medial pectoral nerve. The medial pectoral nerve, it pierces the pectoralis minor to innervate pectoralis major. And the lateral pectoral nerve pierces, come on, tell me. The lateral pectoral nerve pierces the clavipectoral fascia to innervate the pectoralis major. The pectoralis major at the shoulder joint, it can flex, adduct, and medially rotate the arm at shoulder joint. Okay, So pectoralis major, it could be asked in your spotter. It could be asked as a short note question. Which of the following is a modification of clavipectoral fascia? Yes, give me the answer. Confusing, A, B, C, D. So this is the right answer, isn't it? So clavipectoral fascia, it's a very frequently asked short note. It is a deep fascia of the pectoral region that lies beneath the pectoralis major, isn't it? And what are the two muscles enclosed by this clavipectoral fascia? Subclavius and pectoralis minor, right? Yes, you know that. Structures piercing the cephalic vein, right? The lateral pectoral nerve, the lymphatics, the thoracoacromial artery, right? Yeah. Now, what are the two modifications of this clavipectoral fascia? The suspensory ligament of axilla and the one that you frequently tend to forget. That one I put it as a question, right? The part of the clavipectoral fascia that lies beneath the subclavius and above the pectoralis minor. This area, right, it is thickened and it extends from the coracoid process to the first costochondral junction. What you see here is the first strip. This is the clavicle. So this part of the clavipectoral fascia that extends all the way from the coracoid process to the first costochondral junction and lies beneath the subclavius above the pectoralis minor, that is called as the costocoracoid ligament, right? Injury to the pointed structure. What is this structure pointed out here? This is a very, very, very important image, right? So can you tell me what is the nerve that is pointed out in this image? Please entering it in the comment box. So this is a dissection of the pectoral region. What you see here, this is the pectoralis major muscle. This is pex minor, right? And can you tell me what is this nerve piercing pectoralis minor? The medial pectoral nerve, right? And this one here, going to innervate the pectoralis major. Yes, you're right. It's the lateral pectoral nerve. And this muscle that you see here over the pectoral region, forming the medial wall of the axilla, right? Also the bed for the mammary gland, the serratus anterior. And the nerve, come on, now you'll be able to tell it's the long thoracic nerve. The pointed structure is the long thoracic nerve, which is also called the nerve of Bell or nerve to serratus anterior, right? The other important structures in this image you should be able to make out. This is the latissimus dorsi muscle, and innervating it over here, this one is the thoracodorsal nerve, right? So, come on, the long thoracic nerve. In its injury, what happens? There is paralysis of serratus anterior. And what is the important action, unique action of serratus anterior, right? So it arises from the outer surface of the upper eight ribs. It goes in front of the scapula to insert into the medial border costal surface. So contraction of the serratus anterior will pull the scapula forwards, causing protraction, right? So, injury to the long thoracic nerve, inability to protract shoulder. Again, this long thoracic nerve, it's frequently pinned or tied as a spotter question. You can get it as a 5-mark question. Okay, and your OSPI chart, winging of scapula. Yes, that is definitely that. So what you see here is the winging of scapula. What do you mean by the term winging of scapula? So what is this patient doing? Appreciate it. He is pushing his arms, right, against the wall. And while doing that, what is happening? The medial border and the inferior angle of the scapula, it becomes very prominent, right? Why does it become prominent? It is abnormal, isn't it? So injury to the long thoracic nerve, the serratus anterior, which is supposed to protract, that's not possible. And you know that, right? The rhomboids, minor, major, they are the retractors attached to the medial border. So when the protractor is not working, the antagonists, the retractors, they try to pull the scapula towards the midline. This makes the medial border very prominent. Okay, so that is what we call it as winging of scapula, characteristically seen in long thoracic nerve injury. Winging of scapula, long thoracic nerve injury. And come on, tell me, what is the origin? Yes, Dr. Subha, very good. Keep answering right. Thanks for your answers. Your answers are right. Okay. So the long thoracic nerve, yes, it originates from the roots of the brachial plexus. Come on, tell me what is its root value? C5, C6, and C7, isn't it? Okay. Now, if they are going to frame you a MCQ question with case scenario for long thoracic nerve, you should know what are the conditions where it can get injured. Come on, tell me. What are the conditions in which the long thoracic nerve can get injured? Yes, it lies over the medial wall of the axilla. So during lymph node dissection of the axilla. And then we know that the serratus anterior, it forms one of these structures for the mammary bed, right? So during radical mastectomy procedures, radical mastectomy, axillary lymph node dissection, can injure the long thoracic nerve. It is at risk during these procedures. Accidentally, it can get injured, leading to paralysis of serratus anterior. The muscle paralyzes serratus anterior. So if they want to frame a case scenario for this, yes, these are the two clues you have to look for. Yeah, what is the mode of injury and what is the deformity produced? Okay. Come on, tell me. The pointed structure is a branch of. So whenever an image you get, just orient to it. What you see here is the scapula. Is it the costal surface or the dorsal surface of the scapula? What you see here is the spine, right? So it's definitely the it's definitely the dorsal surface of the scapula, right? Then medial and lateral. So this is the medial border. Over here, you see the acromion process. Yeah. And this is medial, and this is lateral. So the pointed structure is related to the lateral border of the scapula. You can see it winding around the lateral border. Come on, tell me, what is this artery winding around the lateral border? It's the circumflex scapular artery. Where does it come from? We know the axillary artery, the course of the axillary artery is divided into three parts by which muscle? Yes, doctors, come on, please answer me. Right? Pectoralis minor. From the first part, we have the superior thoracic artery. From the second part, what are the two branches? Lateral thoracic, thoracoacromial. From the third part, three branches. What are they? Anterior circumflex humeral, posterior circumflex humeral, and subscapular artery. Do you know the subscapular artery is going to divide into two? Yes, what are the two branches? The subscapular artery is the largest branch of axillary artery. It divides into thoracodorsal and circumflex scapular artery. This circumflex scapular artery is also related to the upper triangular space, isn't it? So this is the circumflex scapular artery from the third part of axillary artery. What is this artery you see along the medial border? We call it as the transverse cervical artery, right? And over the upper border, this is the suprascapular artery. Please remember the transverse cervical and suprascapular artery are branches of subclavian artery, right? Now, the question is, right? The pointed structure is circumflex scapular. It is from the third part of axillary artery. But the important thing, I made this question simple, right? But actually, that what I want you to know is that the anastomosis around scapula is between, yes, the third part of axillary artery, the branches of third part of axillary artery and the branches from the first part of subclavian artery. So please underline this, okay? So that is what the option will be. First part, second, third part, third, first part, all that will be confusing. Please remember the anastomosis around scapula is between the branches of third part of axillary artery and first part of subclavian artery. So I told you the muscle dividing axillary artery into three parts is pectoralis minor. And we discussed the branches of axillary artery, right? And then we have the subclavian artery. Anyone, did you try to find out what is the muscle that divides the subclavian artery into three parts? Anyone? Chocolate question? Yes, scalenus anterior. Okay. So we told that this anastomosis is between the branches of the first part of subclavian artery, right? So what are the branches from the first part of subclavian artery? VIT, vertebral artery, internal thoracic artery, and the thyrocervical trunk, right? The thyrocervical trunk will divide into three: SIS, suprascapular artery, inferior thyroid artery, and right, the superficial cervical artery or the transverse cervical artery. Okay, so the details of it we'll be learning even more in head and neck. For just now, remember anastomosis around scapula is between the branches of first part of subclavian artery and third part of axillary artery. Come on, another easy question. Match the following muscles with the actions at shoulder joint, right? So subscapularis. Can you tell me something about the subscapularis? It originates from the subscapular fossa. Where does it go for insertion? Into which part of the humerus? Into the lesser tubercle of humerus, which is on the medial aspect, and that will cause medial rotation. And another thing, the subscapularis is also a hybrid muscle. What are the nerves innervating it? Upper subscapular and lower subscapular. Pectoralis major is again a hybrid muscle. Medial pectoral nerve, lateral pectoral nerve. Any other hybrid muscles of upper limb? Anyone? In the arm? Brachialis, musculocutaneous nerve, and the radial nerve that carries the proprioceptive fibers. In the forearm, flexor digitorum profundus. The medial half innervated by ulnar nerve and the lateral half innervated by the anterior interosseous nerve branch of median nerve, isn't it? Right. Supraspinatus. The supraspinatus, what are the rotator cuff muscles? Can someone name the rotator cuff muscles? Supraspinatus, infraspinatus, teres minor, and subscapularis, isn't it? So supraspinatus, infraspinatus, and teres minor, they all insert into the greater tubercle that is on the lateral aspect. Okay. This supraspinatus muscle, yes, can you tell me what is its action? That is responsible for abduction, initiates abduction. Okay. The first 15 degree of abduction is caused by the contraction of supraspinatus. When you write your theory exam, this angle that you see between the trunk and the arm, right? That is because of the supraspinatus muscle. It initiates abduction, right? Infraspinatus that inserts into the greater tubercle, which is on the lateral aspect of the humerus. That causes lateral rotation. Latissimus dorsi, you know what is its other name? Swimmer's muscle. It helps to extend your arm, take it back, backstroke during swimming, right? It's the main extensor, chief extensor of the arm at the shoulder joint, latissimus dorsi. Got it right? Okay. And nerve supply of subscapular is we saw. Yes, upper and lower subscapular nerve from the posterior cord of brachial plexus. What is the nerve supply of supraspinatus? Suprascapular nerve. Infraspinatus, suprascapular nerve from the upper trunk at Erb's point. Latissimus dorsi, thoracodorsal nerve from the posterior cord. Yes, I'm sure you'll not have a problem in identifying the muscles, right? Trapezius, latissimus dorsi, okay, the levator scapulae, rhomboids minor, rhomboids major, supraspinatus, infraspinatus, teres minor, and teres major, right? Subscapularis over the subscapular fossa. Now, my question is, can you tell me, yes, what is the abnormality in this picture? This is left and this is right shoulder. Which side is abnormal? You can keep entering in the comment box. Yes, you can definitely note the right side is abnormal. Okay. What is the abnormality that you note in the right side? Come on. Shoulder drop. Can you tell me what is the muscle paralyzed in this condition? Which of the muscles of the back do you think is paralyzed in this condition? Waiting for your answers. Which of these muscles of the back helps you to elevate your shoulder, to shrug the shoulder? Yes, trapezius, right? Trapezius. And the trapezius is innervated by spinal accessory nerve, the 11th cranial nerve. Injury to the spinal accessory nerve can paralyze the trapezius muscle, leading to shoulder drop. And please don't confuse this with what is this muscle that you see here? Deltoid, right? Deltoid is a muscle present over the shoulder. It gives the rounded contour for the shoulder. Okay. And this shoulder drop, patient levator scapulae, the name itself tells, right? It elevates your scapula, right? And that is one smaller muscle. This upper fibers of the trapezius, right? It helps to shrug your shoulders, elevate your shoulders, and typically seen in spinal accessory nerve injury. Okay, doctor? Thank you. Right. Come on, this is another interesting question. We can frame it into an essay question also. A 40-year-old male met with an accidental fall, and this is the X-ray taken immediately after the fall. Yes, the nerve injured in this condition innervates which of the following muscle? Yeah, this is abnormal or normal? You see the clavicle, right? You see the scapula. This is the glenoid cavity. The head of the humerus is in out of position. It's not in contact with the glenoid cavity. What do you call this as? Shoulder dislocation. What is a common dislocation of shoulder joint? Yes, antero-inferior dislocation or subcoracoid dislocation. What is the nerve that is injured in this condition? Come on, waiting for your answers. What is the nerve injured in this condition? This is very, very, very important. I'm sure definitely you'll be able to tell me. Yes, guys, come on. It arises from the posterior cord. Why not posterior commonest? Yes. Which part of the capsule is weak? The shoulder dislocation is most commonly involving the antero-inferior part, right? Because yes, you know, the rotator cuff muscles, they support it superiorly and posteriorly. The joint as such, the capsule as such, it's receiving least support in the anterior part, antero-inferior part. Okay, subcoracoid dislocation. Very good, doctor. The nerve injured is the axillary nerve. It winds around the surgical neck of humerus, right? So, the nerve injured in this condition innervates which of the following muscle? Easy. The axillary nerve innervates deltoid and teres minor. Does it have any cutaneous component? Yes. Axillary nerve is again a very important topic, frequently asked 5 mark question. It could be a spotter, MCQ, OSP somewhere, okay, but definitely you'll get it in your upper limb IA. Yes. So the axillary nerve, yes. What is its other name? You must have learned what is the musician's nerve. Ulnar nerve, we call it as musician's nerve because it innervates most of the intrinsic muscles of the hand. Laborer's nerve, median nerve, because it's going to innervate most of the muscles of the thumb, and we need the thumb for most of the gross movements of the hand. Right? Do you know what is the other name for radial nerve? Anyone? Since it traverses the spiral groove and supplies a lot of muscles in the posterior part of the upper limb, it's called the musculospiral nerve. And the other name for axillary nerve, since it winds around the surgical neck of humerus, we also call it as the circumflex nerve. Root value C5, C6 from the posterior cord of the brachial plexus, right? It winds around the surgical neck of humerus. Very good, Dr. Shruti. Yes, that was the right answer. Right. And yes, the intermuscular spaces of axilla, the upper triangular, the lower triangular, the quadrangular space, they are frequently asked in spotters. In your MCQ 5 mark question, axillary nerve is related to quadrangular space. And what is the structure accompanying it? The posterior circumflex humeral artery. Right. You told me it supplies two muscles, the deltoid and teres minor. Does it have any cutaneous branch? Very important. Yes, come on, tell me. The arm on the lateral aspect, right? The upper lateral cutaneous nerve of arm. That is a branch, cutaneous branch of axillary nerve, right? So what happens in axillary nerve injury? The patient presents with loss of sensation over the upper lateral part of the arm. And because the soldiers wear their badge there, right? You must have learned or seen in your textbooks. We call it as the regimental badge of anesthesia. Important MCQ, right? Upper lateral cutaneous nerve of arm, branch of axillary nerve. And then again, another important MCQ. How does it terminate? There are very few nerves in the entire human body which terminate as a pseudoganglia. Ganglia, it is a collection of cell bodies. So what is the pseudoganglia? The terminal part of the nerve, it just ends as a swelling. It doesn't have collection of cell bodies. We call it a pseudoganglia. So the axillary nerve, the branch of it that goes to supply the teres minor. The nerve to teres minor, it ends as a pseudoganglia. One more nerve in upper limb that ends as a pseudoganglia. Come on. One more nerve in upper limb that ends as a pseudoganglia is MCQ, posterior interosseous nerve. And one nerve in lower limb that ends as a pseudoganglia. Come on, anyone? The deep peroneal nerve. It ends by supplying that extensor digitorum brevis over the dorsum of the foot, right? It ends as a pseudoganglia. Yes. So if I want to frame a case scenario for a MCQ question related to axillary nerve, I had to think about its mode of injury. So what are the scenarios under which this axillary nerve can get injured? Yeah, just now we saw, right? What was the example we saw now? Dislocation, shoulder dislocation, or fracture to the surgical neck of humerus, isn't it? So I should frame a scenario, and these are the terms you have to look for as a clue in a case scenario, right? Axillary nerve coming from your general anatomy. It obeys Hilton's law. What does the Hilton's law state? A nerve that supplies the joint also supplies the muscles acting on the joint and the skin over the joint. This axillary nerve, it innervates the shoulder joint, the muscles acting over the shoulder joint, the deltoid and the teres minor, and also the skin over the shoulder joint. So it obeys the Hilton's law. So what are the features of axillary nerve injury? Deltoid, teres minor, and then the upper lateral cutaneous nerve of arm, isn't it? Injury to the deltoid, the patient will not be able to abduct the arm up to 90 degree, right? Painful abduction. So whenever he tries to abduct, it's going to be painful. So he will not be abducting his arm and he will not be using his deltoid further. Once it's not used, then the muscle will go for atrophy wastage. You know that the round contour to the shoulders given by the deltoid muscle, isn't it? So, what will happen if there's wastage of deltoid, atrophy of deltoid? That round contour is lost. Can you appreciate a well-built normal deltoid here? An atrophied deltoid, right? Teres minor, it is one of the muscle that causes lateral rotation, abduction at the shoulder and upper lateral cutaneous nerve of arm. So loss of sensation over the regimental badge area. So that's all about the axillary nerve. A very, very, very important question. Definitely you'll get either as MCQ or spotter or short note, right? Or speak. So this again was one neat PG question. Identify the incorrect statement of the structure injured in this condition. What is this bulk that you see in the middle of the arm? Anyone? I know your textbooks mention it. Yes. Normally, when you show a well-built biceps, right? How it will appear and how it is here. What is this condition? Your normal biceps that is not present, it's looking like a hump there. This is the rupture of the tendon of biceps. Very good, Dr. Arun. Very good. Rupture of biceps tendon, and we call it as, come on, Popoy's deformity, right? Poppy's deformity. Rupture of the long head of biceps. Okay, so we know this again could be a very important short note for you. The biceps brachii that you see here, it has a long head coming from the supraglenoid tubercle, intracapsular in origin, and the short head coming from the coracoid process of the scapula. What is happening to the biceps tendon? The tendon is going for insertion into the radial tuberosity. What about the bicipital upper neurosis? That is going for insertion into the ulna, the posterior subcutaneous border of the ulna, and it is innervated by musculocutaneous nerve coming from the lateral cord of brachial plexus. Yes, Dr. Alia, very good. What are the actions of this biceps muscle? At the elbow joint, it flexes the elbow, it supinates the forearm, right? At the radio-ulnar joint. So let us see the question now. Identify the incorrect statement of the structure injured in this condition. The structure injured in this condition is the biceps. It arises from scapula, of course, from the supraglenoid tubercle and the coracoid process of scapula. It is inserted into ulna. Yes, the bicipital upper neurosis goes for insertion into ulna. It supinates the forearm. It is not a hybrid muscle. We have seen the list of hybrid muscles in upper limb, right? Pectoralis major, subscapularis, brachialis, flexor digitorum profundus. Again, this is a very interesting question from your NEET PG entrance examination. A patient with multiple fractures of humerus severe weakness of flexion and supination, and loss of cutaneous sensation over the lateral aspect of forearm. The nerve injured is musculocutaneous nerve, very, very frequently tied in your spotter examination. You know the musculocutaneous nerve, it comes from which cord of the brachial plexus? Lateral cord, right? You must have seen it piercing the coracobrachialis muscle. It supplies the coracobrachialis, the biceps, and the brachialis. And how does it terminate? It continues as the lateral cutaneous nerve of forearm, right? Very, very, very important. Very frequently asked in your spotter. Now, this is one a, indirect question. Let me see how many of you get it right. Identify the correctly matched option A, B, C, D. So I'll just zoom in these images. A. So what is that you see here in A? Fracture of surgical neck of humerus. And what is the nerve injured here? Axillary nerve. Right. B. You see the lower end of the humerus, you see the radius here, you see the ulna here. So this is going to be lateral epicondyle. This is the medial epicondyle. So this is the condition showing fracture of medial epicondyle. Come on, tell me, what is the nerve injured here? Ulnar nerve, right? See, fracture of shaft of humerus, isn't it? And what is the nerve injured here? Radial nerve. And here, yes, what is this? Supracondylar fracture of humerus. What are the two structures that are getting injured in this condition? Supracondylar fracture of humerus is common in children. Yes, Shanmuga Bharati. Very good, Alia. Right? Supracondylar fracture of humerus that injures the median nerve. And one more structure, the brachial artery. Right. So we have seen the images. Now let us see the options. Winging of scapula. Fracture surgery. Fracture surgical neck. Axillary nerve. Yeah, it's not going to result in winging of scapula. Tennis elbows due to inflammation of which part of the humerus? Lateral epicondylitis. Golfer's elbow is medial epicondylitis. C is radial nerve injury. Claw hand is seen in which nerve injury? Claw hand will be seen in injury to both ulnar nerve and median nerve. What is the muscle that's responsible for clawing? Paralysis of which muscle will lead to clawing? Yes, the lumbricals, isn't it? Yeah. And D, median nerve injury, right? That will lead to ape thumb. Ape thumb, you're not able to bring the thumb in contact with the other digits. Opposition is not possible. This is called ape thumb. Yes, Dr. Alia, Ashrit, Vihar, right? Very good, guys. Very good. Okay. So please remember, this is a very important topic. Yes, Vihar, very good. The nerves that are related to humerus. Around the surgical neck, that we have the axillary nerve. And the shaft of the humerus in the spiral groove, the radial nerve. Behind the medial epicondyle, ulnar nerve. Supracondylar fracture, median nerve. Okay, again, lot of MCQs, lot of case scenarios can be framed for each nerve. This is again one important question, right? Yes, mammary gland, yeah, a frequently asked essay question. Lymphatic drainage of mammary gland alone can be a 5-mark question. Involvement of which structure is responsible for dimpling of skin seen in breast carcinoma? Let us label A, B, C, D. What is A? A is the ligaments of Cooper, suspensory ligaments of Cooper. D is the secretory part, the acini. B is the lactiferous ducts that are going to open into the nipple. And D is the retromammary space. Dimpling of skin. Come on, give me the answers. Dr. Alia, Vihal, Shubha, come on, guys, yes, you know the answer. Dimpling of skin. I know beauty orange, everyone will get it right. What is dimpling of skin? Can you appreciate the skin dimpling here? Carcinoma breast. If the malignant cells infiltrate into Cooper's ligament, you will get to see dimpling of skin. This Cooper's ligament, right? It extends all the way from the mammary bed. It very good, Dr. Shruti. All the way from the mammary bed, okay, through and through the parenchyma to the overlying skin. So when the malignant cells infiltrate into it, it will pull and the skin gets a dimple puckering. Retraction of nipple. So what you see here is retraction of nipple. What is the anatomical basis for retraction of nipple? What did we see inside the nipple? The lactiferous duct. Infiltration of malignant cells into the lactiferous duct. That is going to result in retraction of nipple. Once you understand, you're not going to make a mistake. And please remember, the anatomy of mammary gland, everything is not confined to first MBBS alone, right? In your final year, breast malignancy, swellings are right, tumor of the breast, yeah, any swelling of the breast is going to be a long case for you. And then fixity. Normally, we know the mammary gland is mobile over the chest. If what happens? If there is fixity of the breast tissue, it means that the malignant cells has infiltrated into the retromammary space. And this one, very commonly asked, I'm sure everyone will get it right. What is it? Pudy orange appearance. What is the anatomical basis for the pudy orange appearance? So if I zoom in, what are these pits that you see here? That is the region of the hair follicle. And the area between the pits, you see it's sort of puffed up, right? Why is it puffed up? Because, yes, the the lymph in that area is not drained due to infiltration of malignant cells into the subcutaneous or the subdermal lymphatics. There is a blockage of the subcutaneous or the subdermal lymphatics. So the lymph in that area is not drained and that area looks edematous, puffed up. This is called as pudy orange appearance, right? Moving on to the next question. Again, I'm trying to put a lot of clinical scenarios so that you understand the concept and you'll be able to apply it further. In this clinical condition shown, which group of axillary lymph nodes will enlarge? Can I have your answer? How many group of axillary lymph nodes are there? So the pectoral is the anterior group, subscapular is the posterior group, humeral is the lateral group, right? There is some infection, some abscess of the thumb. The lymphatics of the thumb, they drain into which group of axillary lymph nodes? Come on. The axillary lymph nodes is again another short note question for you, right? So you have the anterior, the posterior, the lateral, the central and apical group. So you should know where are they located. The anterior or the pectoral group, right? It lies in the pectoral region along the lateral thoracic vessels. The posterior group in the posterior wall of axilla along the subscapular vessels. And the lateral group, yes, in the in the lateral wall of axilla along the axillary vein. It's called the humeral group. The central group in the base of the axilla and the fat, and this is the apical group, right? Okay, the anterior or the pectoral group, yes, you can tell me the afferent to it mainly comes from the pectoral region, above the umbilicus, and also mainly from the mammary gland, right? Okay, and posterior group from the back from the we saw the muscles of the back, right? So from the back region, from the scapular region, all the way up to the iliac crest, right? And the lateral group, it receives the lymphatics from the upper limb, excluding the lymphatics that accompany the thumb, okay, that travels. So what happens is the lymphatics of the thumb, they, very good, Dr. Tangamani. The lymphatics of the thumb, they travel, they accompany the cephalic vein, right? And they reach the infraclavicular group of lymph nodes. From that to the apical group of lymph nodes. Whereas the lymphatics of the other digits, right? Other digits, mainly the thumb and index finger will accompany this. The lymphatics of the middle finger, the ring finger, little finger, they will reach the lateral group of lymph nodes. So infection of the little finger, lateral group of lymph nodes will be enlarged. Infection of the thumb, we can get to see enlargement of the infraclavicular or the apical group of lymph nodes, right? So you must have learned all this. Where is it located? What is the afferent? What is the efferent? But you should be able to understand. You should understand the concept. Then you'll be able to interpret it in a clinical scenario. Which of the following is not from supraclavicular part of brachial plexus? Brachial plexus itself is an essay question, right? But the parts of it, Erb's palsy, Klumpke's palsy alone, brachial plexus injuries alone can be a short note. And a lot of MCQs are going to be coming from brachial plexus topic. So you know that brachial plexus, yeah, what you see here, the roots, the trunks, they lie in the neck, posterior triangle of the neck, above the clavicle. And beneath the clavicle, you can see the divisions. So what do you mean by supraclavicular part of brachial plexus? It will include the root, the trunk, and the divisions. Can you tell me what are the branches coming from the supraclavicular part of brachial plexus? From the root, we have the long thoracic nerve, the nerve to serratus anterior, the dorsal scapular nerve or the nerve to rhomboids, accessory branch to phrenic nerve. Any branch from the trunk of brachial plexus, from the upper trunk at the Erb's point, we have the suprascapular nerve and the nerve to subclavius, isn't it, at Erb's point? Right. And please remember, there are no branches from the division component of the brachial plexus. Okay, then we have the cords and the branches from the cords. What are the three branches from the lateral cord? Lateral pectoral nerve, musculocutaneous nerve, lateral root of median nerve. From the posterior cord, medial root of median nerve, medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve forearm, and ulnar nerve. From the posterior cord, upper subscapular, lower subscapular, thoracodorsal, radial nerve, axillary nerve. By now, you should have it all at the tip of your fingers, right? And yes, what is the only nerve of the brachial plexus which has the root value C6, C7, C8, and you cannot confuse it with any other one? Anyone? Easy. Waiting for your answers. Come on. Yes. Very good, doctor. Thoracodorsal. Shruti, Varsha, thoracodorsal nerve. And recently in my dissection table, I was questioning them. Which muscle that you learn in upper limb is not supplied by brachial plexus? Latissimus dorsi is thoracodorsal nerve, Shruti. Yeah, you've got it right, Shruti. Which muscle in upper limb that you learn is not going to be innervated by brachial plexus? Just now we saw in one of the MCQs also. The muscle that causes the shoulder drop, trapezius, innervated by spinal accessory nerve, right? I think other than that, almost all the muscles that you learn in upper limb is going to be innervated by the branches from brachial plexus, right? So here, coming to the options, nerve to serratus anterior, long thoracic nerve, nerve of Bell with the root value C5, C6, C7, comes from the roots of brachial plexus. nerve to rhomboids or the dorsal scapular nerve with the root value C5 from the roots of the brachial plexus. Nerve to subclavius C5, C6 from the upper trunk at Erb's point. This is the odd one out. Very good. Yes. A 30-year-old driving motorcycle at a high speed collided with, yes, Dr. Varsha, with tree and was thrown on the left shoulder. X-ray was normal. Yes, this is a very typical scenario. Left arm medially rotated and adducted. Elbow extended, forearm pronated. All the following nerves are involved in this condition except. Come on, tell me what is this condition? The arm is medially rotated, adducted, elbow extended, forearm pronated. Correct. No issues, Raghu, I understand, right? Thank you. So here what is shown is, yes, it characteristically describes the Erb's palsy, isn't it? And they've asked you which of the following, all the following nerves are involved. Yes, Dr. Shruti, Dr. Ashrit, very good. What is the nerve that is not involved in Erb's palsy of the four options given? Very easy. Yes, it's not a difficult question. So Erb's palsy is injury to the upper trunk of brachial plexus. Right? Yes, Dr. Shanmugh. Erb's point. What is Erb's point? Right? C5 and C6 uniting to form the upper trunk. That is going to divide into anterior division, posterior division. And the two nerves that come from here, suprascapular nerve and nerve to subclavius. So this angle, the angle between the neck and the shoulder, that is getting stretched at the Erb's palsy. Right. And now, how to easily remember the nerves involved in Erb's palsy? I've taught it to my students, right? Yes, we expect, but we don't get, right? So remember, manners. These are the nerves that are involved in Erb's palsy. Musculocutaneous nerve, axillary nerve, nerve to subclavius, radial nerve, and suprascapular nerve, right? What are the muscles paralyzed? Musculocutaneous nerve, உங்களுக்கு தெரியும். All the three muscles in the arm, என்னலாம்? Coracobrachialis, biceps brachii, and brachialis. Axillary nerve innervates deltoid, teres minor, subclavius, radial nerve. In this condition, we are talking about its nerve supply to supinator because Erb's palsy patients having a difficulty in supination, right? Suprascapular nerve innervates supraspinatus and infraspinatus, right? So this is the right answer. Okay. Again, this is a very important spotter, cubital fossa. What are the structures present? Let us see here. Orientation. உங்க spotter examல கூட நீங்க specimen முன்னாடி போய் நிக்கும் போது take some time to orient to it. Whether it's flexor surface or dorsal surface, front or back, whether it's arm or forearm, medial or lateral, look for some landmark, okay? So in the question, can you tell me what is the pointed structure? Which is medial and lateral here? This is the biceps tendon. Can you make out the brachial artery here? This is the median nerve. The one pointed out is the radial nerve. Another important clue here, right? This is the medial epicondyle. The medial epicondyle is more pointed, jutting out rather than the lateral epicondyle, right? So this is a cadaveric image of the cubital fossa. And you know, the arrangement of structures from medial to lateral is MBBR. So the lesion of the market structure. Radial nerve injury என்ன இருக்கும்? Yes, radial nerve injury. Just one word. Very good. Wrist drop. Okay. And so many questions can be asked over this region. They can ask about the biceps tendon, its insertion, nerve supply action, right? And brachial artery. What is the level of termination of brachial artery? Neck of radius, isn't it? And what are the branches of radial artery, ulnar artery here in the cubital fossa? The radial artery will give only radial recurrent artery. What are the branches of ulnar artery here in cubital fossa? Anterior ulnar recurrent, posterior ulnar recurrent, common interosseous artery that divides into anterior interosseous artery, posterior interosseous artery, and posterior interosseous artery will give interosseous recurrent artery. இது எல்லாமுமே தெரிஞ்சிருக்கணும், okay? They can pin any structure and they can put forward any question. Again, here, what is ABCD? What is medial lateral here? You can make out the thenar and hypothenar here. This is medial and this is lateral. This muscle that you see here is the pronator teres. Next to pronator teres, flexa carpi radialis. This is palmaris longus. This is flexa carpi ulnaris. If you lift flexa carpi ulnaris, what you see here will be ulnar nerve and ulnar vessels. Over here, this is the brachioradialis, right? This nerve in the upper two-thirds of the forearm, it has a very deep course. In the lower part, wrist பக்கத்துல வரும்போது, it becomes very superficial. What is this nerve here, which is very liable to injury during suicidal cuts at the wrist joint? This is the median nerve. Okay. So this will be the incorrectly matched one. இது மெயினா போட்டது அப்பர்ல முடிச்சதுக்கு அப்புறமே நிறைய பேத்துக்கு ஃபோராம் ஸ்பேஸ் ஆஃப் பரோனான்னு ஒன்னு இருக்கிறது தெரியாது, ரைட்? இட் குட் பி an MCQ or 5-mark question also for you. The forearm space of parona, it lies in the forearm. Flexor compartment, extensor compartment, flexor compartmentல distal partல, right? Deep to the long flexor tendons and superficial to pronator quadratus and the interosseous membrane, right? So the pronator quadratus பத்தி படிச்சுக்கோங்க. Okay. The forearm space of parona, deep to the flexor tendons, superficial to the pronator quadratus and interosseous membrane. Yes, coming to nerve injuries. A 28-year-old, 28-year-old 10 weeks healthy pregnant women awoke one morning with swelling, unbearable pain in the dominant right hand wrist, extending to the middle fingers. The pain was cramping and got aggravated whenever she tried to move her wrist. She complained of tingling and paresthesia in the lateral 3.5 fingers. In the case scenario, main clue இதுதான். What is the nerve supply to lateral 3.5 digits? Come on, give me answers. Yes? Lateral 3.5. Lower limb, we learn cutaneous innervation of dorsum of foot, right? Okay. So each nerve, a case scenario can be formed for it. அதே மாதிரி cutaneous innervation of hand is equally important. The nerve supply to lateral 3.5 digits is by median nerve. And this is a typical, very good Dr. Ashrit. And this is a typical case scenario. Very good Dr. Madhumita Shanmuga Bharati. Okay, this is a very typical case scenario of Carpal tunnel syndrome, right? We know that. Very good, Dr. Chandreshwar. Okay. So we know that the median nerve, it goes beneath the flexor retinaculum through the carpal tunnel. Yeah. And it gets injured. What are, yeah. So we'll read the conditions. Carpal tunnel syndrome is caused by compression of median nerve. Is right. There is no sensory loss over thenar eminence. I want a yes or no. Carpal tunnel syndromeல median nerve compress ஆகுது. Median nerve வந்து thenar muscles supply பண்ணும். So median nerve injuryல thenar muscles will go for a atrophy. What about the sensation over the thenar eminence? Thenar atrophy இருக்கு patientக்கு. You take a pin and prick over the skin over thenar eminence. Will he be able to feel the pain in carpal tunnel syndrome? Yes or no, please? Come on, Madhumita. Viha, Ashrit, Vigar, Subha. Yes, guys, we're nicely interacting. This is a very important question. What is this? Oh my, yeah, yeah. So please remember, you know, this again, flexor retinaculum is a very important 5-mark question. Structures passing deep to it. Yes, Ashrit, very good, right? Structures passing deep to it, superficial to it, like important MCQ. Okay, attachment of flexor retinaculum. So structures passing deep to the flexor retinaculum, flexor digitorum superficialis, flexor digitorum profundus, and the, very good Alia, and the ulna bursa. Adhe mari flexor pollicis longus is surrounded by the radial bursa. This is flexor carpi radialis. This is median nerve. So what are the reasons for carpal tunnel syndrome? Anything that you can reduce the space beneath the flexor retinaculum within the carpal tunnel, inflammation of the radial bursa, inflammation of the ulnar bursa, right? Or myxedema, thyroid, hypothyroidism, pregnancy, volume overload conditions, and even one more. The carpal bones tunnel, the concavity is bridged by the flexor retinaculum. So if you imagine, இது வந்து hook of hamate இருக்குது. So you have the scaphoid. I have a picture there. So structures passing superficial to flexor retinaculum, please. Yes. Ulnar nerve and ulnar artery in the Guyon's canal. Palmar cutaneous branch of ulnar nerve. Palmar is longest. And here comes the palmar cutaneous branch of median nerve. Median nerve goes deep to flexor retinaculum. Ana, அந்த ஸ்கின் ஓவர் தீனார் மசில்ஸ் இருக்கு இல்லையா, அதை சப்ளை பண்ற பாமா cutaneous branch, it goes above the flexor retinaculum, guys. Okay, so carpal tunnel syndromeல அடி வாங்குறது median nerve தான், but palmar cutaneous branch of median nerve, it escapes. So carpal tunnel syndromeல there'll be atrophy of the thenar muscles, but if you take a pin and prick the skin over the thenar eminence, patient is going to shout in pain. Okay, there is no loss of sensation over the skin of thenar muscles, though there is thenar atrophy. அப்படிங்கிற கான்செப்ட தான் நான் ஏத்த ட்ரை பண்றேன், right? So this is also right. And third option, similar condition can also be caused by posterior dislocation of lunate bone. Come on, let us identify. This is lower end of radius, lower end of ulna. You can make out the styloid process. What is the name given to fracture of distal end of radius? Dinner folk deformity ke enna peru? Yes, Foley's fracture, right? Back dorsal displacement of the distal fragment. Yeah, this is scaphoid, this is lunate, triquetral, pisiform. Pisiform is a sesamoid bone within the tendon of flexor carpi ulnaris. Trapezium, trapezoid, capitate. Capitate, the largest of the carpal bone, and this is the hamate. இங்க பார்க்கிற lunate இருக்கு இல்லையா? This lunate bone, it frequently undergoes anterior dislocation. So anterior dislocation என்ன ஆகும்? It is pushed into the carpal tunnel. That will reduce the space within the carpal tunnel. Okay, so that is the wrong answer. Not posterior dislocation, anterior dislocation. Yes, Dr. Alia, very good. Flexor retinaculum has to be cut to relieve these symptoms. Okay, இன்னொரு வார்த்தை சொல்லி கொடுத்துட்டேன். You must have learned about avascular necrosis. Avascular necrosis of lunate bone, it is called as Kienbock's disease. It's there in Gray's Anatomy, right? I don't think UG textbooks that has come into. Avascular necrosis of lunate bone, it's called as Kienbock's disease. This is an easy question. The about test, what is the about test here? This is the pen test. So these are the actions of the thumb: flexion, extension, adduction, abduction. So for abduction, you have to lift your thumb up to touch the pen. And this is to test abductor pollicis brevis, that is innervated by median nerve. Abductor pollicis longus is innervated by the radial nerve, posterior interosseous nerve branch of radial nerve. Okay, but that's inserts into the base of the first metacarpal. It doesn't cause, it's not inserting into the phalanges of your thumb and moving the thumb, right? So pen test is for abductor pollicis brevis, median nerve. And I'm sure, come on, quickly tell me, what are the muscles innervated by median nerve in the hand? So the three thenar muscles, what are they? Abductor, remember the abductors are always in the border, right? Solely அப்படிதானே படிச்சோம். Abductors are always in the border. Abductor digiti minima இங்க இருக்குன்னா, இந்த இடத்துல இருக்கிறது abductor pollicis brevis. You have the abductor pollicis brevis, flexor pollicis brevis. ரெண்டையும் lift பண்ணிட்டு இல்ல பிரிச்சுட்டு கீழே டீப்பா பார்த்தோம்னா தான் we get to see the opponent's pollicis. These are the three thenar muscles. Other than that, the first and the second lumbricals are innervated by median nerve. All the other muscles are going to be innervated by the ulnar nerve. What are the, இதுவும் frequently asked potter. These are the lumbricals. The first, second, third, and fourth. First and second lumbricals are unipennate, innervated by the median nerve. Third and fourth lumbricals are bipennate, innervated by the ulnar nerve. Remember that the lumbricals, they insert into extensor expansion. At the metacarpophalangeal joint, they flex, and over the interphalangeal joint, they extend. When the lumbricals are paralyzed, you get clawing. Okay, lumbricals alone can be a 5-mark question. It can be a spotter for you. So clawing வந்து median nerve and ulnar nerve injury-ல இருக்கும். Yes, can you identify these muscles here? So these are the palmar interossei, right? And here they are unipennate. These are the dorsal interossei. Dorsal interossei எல்லாமே bipennate. This is your first dorsal interossei. Can anyone tell me what is this artery that you see that passing between the two heads of the first dorsal interossei? The artery passing between the two heads of the first dorsal interossei is, very good, the radial artery, right? Action of the dorsal interossei, abduction, dab சொல்லி கொடுத்திருப்பாங்க. அதே மாதிரி palmar interossei is adduction. Pad. ரெண்டுமே dorsal interossei and palmar interossei are going to be innervated by the deep branch of ulnar nerve. Injury to the pointed structure results in all the following except. In the pointed structure என்னது? Easy. What nerve is this? Just now we saw, right, under the upper 2/3 வந்து deep இருக்கும், lower part will become superficial, I told you. So this is the median nerve. Now let me, yeah, Vihar, Vijay Bharati, right? Okay, median nerve, right? Now let us read the options. Inability to flex the distal phalanx of the thumb. To flex the distal phalanx of the thumb, we need flexor pollicis longus. Flex the middle phalanx of index and middle finger. What is that muscle that can act over the proximal interphalangeal joint? Flexor digitorum superficialis. Flex the distal phalanx of the ring finger, flexor digitorum profundus. For pronation, yes, we need pronator quadratus and pronator teres. Okay. So, இப்ப இதுல எதெல்லாம் median nerve supply பண்ணுது? Flexor pollicis longus is innervated by median nerve is right. Flexor digitorum superficialis is innervated by median nerve is right. Pronator quadratus, pronator teres, both the pronators are innervated by median nerve. Okay. And flexor digitorum profundus to the ring finger as well as the little finger. That is innervated by ulnar nerve. Got it? Now, yes, these are all the tests to diagnose median nerve injury. நீங்க அது என்ன டெஸ்ட் என்ன மசில் paralyzed அப்படின்னு மட்டும் சொல்லிடுங்க. Right. So this is hand of benediction. Not able to flex the thumb, distal phalanx of the thumb, index finger or the middle finger. Injury to flexor digitorum profundus. இந்த டெஸ்டுக்கு பேர் என்ன? Ochsner's class test. So you ask the patient to bend all the digits, but index finger மட்டும் மடக்க முடியல. Okay, index finger ஓட flexor digitorum profundus is injured. And just now we saw pen test for abductor pollicis brevis. Ape thumb. What is the muscle that is paralyzed? Opponent's pollicis. And yes, median claw due to paralysis of first and second lumbricals. And this is very, very important. Yes, so what do you see here? Thumb. Thumb border distal phalanx is bent. The muscle that you need for that is flexor pollicis longus. இது index finger ஓட distal phalanx வந்து bent. Flexor digitorum profundus. So to make a perfect O, you have to bend the thumb and the index finger. இதுக்கு பேரு okay sign. In the flexor pollicis longus, flexor digitorum profundus, right? For the index finger and middle finger is going to be innervated by anterior interosseous nerve. So anterior interosseous nerve injury la patient ஆல இந்த மாதிரி ஒரு O பண்ண முடியாது. If he tries to make a O, it will go like this. Understood? Okay? Okay sign. Anterior interosseous nerve injury. Right. Sensory loss over the palmar aspect of lateral 3.5 fingers. We know it is related to median nerve. This was one neat PG question. So, எந்த combination correct னு கேட்டிருக்காங்க. Carpal tunnel syndrome தான். என்னது? Durkin test. So, carpal tunnel syndrome la we have 3 tests. Yeah. I think your textbooks, UG textbooks too, கொடுத்திருக்கும் Durkin கொடுக்கல அன்னைக்கு while discussing in our dissection table, right? So I asked them to know the Durkin's test. So this is Phalen's test. You bring the dorsum of both the wrists together. Tinel என்ன பண்றீங்க? You tap over the median nerve area in the carpal tunnel. Durkin's, you're pressing over it, right? So இப்ப ஏற்கனவே வந்து there is a manifestation of carpal tunnel syndrome and you're doing all this, it will trigger median nerve injury and patient will present with pain paresthesia over the sensory innervation of median nerve over the lateral 3.5 digits. Okay, so please make a note. These are the 3 tests for median nerve injury in carpal tunnel syndrome. To diagnose carpal tunnel syndrome, median nerve compression, Phalen's, Tinel's and Durkin's. அதுக்கப்புறம் in lower limb, we learnt about cutaneous innervation of dorsum of foot. Similarly, cutaneous innervation of hand is very important. On the radian nerve, median nerve, ulnar nerve injury, you're going to get a case scenario. There will be a particular clue as to where the patient is going to present with loss of sensation. That will help you to diagnose which nerve is injured. Okay, so you must be knowing, right? Palmar surface la medial 1.5 What do you mean by that half? Ring finger oda medial aspect, right? Okay, that is innervated by ulnar nerve. Adhe madri, 3.5. So entire thumb, entire index finger, right middle finger entire, and the lateral part of the ring finger, all this is going to be innervated. The skin over this area is innervated by median nerve. Dorsal surface is even more important. Dorsum of the hand, again that 1.5 is ulnar nerve. And 3.5, I'm going to take a different color now because it's not median nerve. It's going to be radial nerve. So dorsum order 3.5 is by radial nerve. The superficial branch of the radial nerve, except over the nail bed area, over the distal phalanx of the thumb, the index finger and the middle finger. That is again by median nerve. Okay. Patient presents with numbness and tingling over the little finger and ring finger with atrophy of hypothenar eminence. Very easy, right? Ulnar nerve injury. Thumbnale, 80% you have to keep median nerve in hand. But we have to think about radial nerve and ulnar nerve also. Adductor pollicis is innervated by ulnar nerve. The extensor abductor pollicis longus is innervated by radial nerve. Okay. Other than that, 80% of the movements of the thumb is going to be caused by muscles innervated by median nerve. Little finger, ring finger, mainly it's going to be ulnar nerve. Okay. And hypothenar eminence, ulnar nerve. So what is true about the ulnar nerve? It passes below the flexor retinaculum? No. It passes above the flexor retinaculum through the Guyon's canal deep to the pisohamate ligament, isn't it? It is the medialmost structure in arm? No. The medialmost structure in the arm is not ulnar nerve. It lies in a groove behind the medial epicondyle is the right answer. It innervates the third and the fourth lumbrical. So median nerve, it could be again a spotter for you, right? Median nerve, it lies medial to the brachial artery. It goes behind the medial epicondyle. Yes, Dr. Gopalika Dharan. Flexa carpi ulnaris தூக்கி பார்த்தோம்னா, you can see the ulnar nerve here. You should be also able to find the ulnar nerve if it is tied in the hand. And what is the muscles innervated by the ulnar nerve? Forearmla flexa carpi ulnaris, flexa digitorum profundus to the little finger and the ring finger. And in the hand, the ulnar nerve, it innervates the palmaris brevis. Please don't forget, okay, the superficial muscle, palmaris brevis, the three hypothenar muscles, the adductor pollicis, the third and fourth lumbrical, and all the interossei, the palmar and the dorsal interossei. Again, this is very important, the test for ulnar nerve injury. So, இங்க என்ன பண்ணிருக்கோம்? Paper, a book, something we're asking the patient to hold. இது வந்து என்ன thumb? This is your right, and this is left. Left thumb, நேரா பிடிச்சிருக்காங்க. Right thumb, can you see a bend here? This is called as the book test for ulnar nerve injury. So the patient tries to hold the book using his adduction of thumb. Adductor pollicis innervated by ulnar nerve. Ulnar nerve injury la adductor pollicis paralyze ஆகிறதுனால adduct பண்ணி பிடிக்க முடியாது. He's trying to hold the paper using flexor pollicis brevis. That is why the thumb is bent. And this bending of the thumb to hold the book, it is called as Fromen's sign. Right? So that is for adductor pollicis. And then ஒரு கார்டை வந்து பிடிக்க சொல்லிட்டு நாம அதை புல் பண்ணணும். Okay? So the patient will try to hold. He shouldn't let the card. Yeah. So he's keeping his fingers adducted, all the digits adducted to hold the card, and that is to test palmar interossei. This is called as the card test for ulnar nerve. And here, middle finger. Middle finger, it lies along the axis of adduction. It will not have any palmar interossei. But you can move it right and left, right. It will be provided with two dorsal interossei. So middle finger, நம்ம வந்து right left move பண்ணி பார்க்க சொல்றோம். This is called as the EGAVA test. It is for testing dorsal interossei, right? Now, this is again an important question. Yes, this is the area of anatomical snuff box. What are the boundaries formed by for the anatomical snuff box? Laterally and medially. Laterally by abductor pollicis longus tendon, extensor pollicis brevis. Medially, the tendon of extensor pollicis longus, the tendon of first compartment and third compartment. So what are the boundaries, other components for the anatomical snuff box? Roof la enna paapinga? What are the structures? Yes, the roof will have the cephalic vein. The cephalic vein is crossed by superficial branch of radial nerve. Very good, Dr. Charaneshwaran. And what is the content of anatomical snuff box? The radial artery. Gopalika, good. Now, yes, what are the tendons passing through the extensor retinaculum? This is again a spotter question for you. Extensor retinaculum, you know its attachment? It is attached to the radius, okay, above the styloid process, medially to the triquetral and pisiform. It is not attached to the ulna, right? So, in the extensor retinaculum மேல பின்ன போட்டு frequent கேக்குறது name the structures passing through its fourth compartment, second compartment அந்த மாதிரி. Okay, so first compartment we saw abductor pollicis longus and extensor pollicis brevis. Second compartment, extensor carpi radialis longus, extensor carpi radialis brevis. Third compartment, extensor pollicis longus. Fourth compartment is very important and examiners love to ask it because there are four structures passing through the fourth compartment. Enala, extensor digitorum tendons, extensor indicis, posterior interosseous nerve, anterior interosseous artery. Fifth compartment, extensor digiti minimi. Sixth compartment, extensor carpi ulnaris. So, if they ask you extensor compartment as a 5-mark question, the applied anatomy that you have write for it, but I think it's not given in your UG textbooks. Please make a note of it. Yeah, D. Quervain tenosynovitis is inflammation of the first compartment tendons. அதே மாதிரி intersection syndrome, that is crossing of first and second compartment tendons. It will lead to pain in that area at that point of crossing. Okay, just for completion's sake. So what is this deformity? What is the injury due to? So we are now going to talk about the extensor expansion. You know that this is your metacarpal, this is your proximal phalanx, middle phalanx, and distal phalanx, isn't it? So extensor expansion எங்க இருக்கு? Triangular expansion, right? Over the base of the metacarpal extending over the proximal phalanx. In the triangular expansion இருந்து, அதோட apexல இருந்து, you have a central slip that will cross the proximal interphalangeal joint. This is your proximal interphalangeal joint and insert into the base of the middle phalanx. This is responsible for the extension of the proximal interphalangeal joint. அதே மாதிரி, there will be two lateral slips. The lateral slips will cross the distal interphalangeal joint and insert into the base of the distal phalanx, responsible for extension of the distal phalanx. So, in the finger la enna prachana? Proximal interphalangeal joint, it is not extended, it is flexed. So, there is injury to the central slip. It's called as the Buttoner deformity. Right extensor expansion. Buttoner deformity. Inga pathingana. You can tell it. So distal phalanx bent இருக்கு. இதை extend பண்ண முடியல. Injury to the lateral slip of extensor expansion. And this condition is called as mallet finger. Extensor expansion இருக்கு. இந்த ரெண்டும் நம்ம கொடுத்துக்கலாம். Applied anatomy. Right? And one frequently asked question. So உங்களுக்கு spotted examல introitious membrane கூட pin பண்ணலாம். Anterior introitious nerve, anterior introitious artery, posterior introitious nerve, posterior introitious artery are all very frequently asked spotters. So in this image, I pointed out at the superior radioulnar joint. You know that this is the radius and this is ulna. There are three joints between the radius and ulna. Superior radioulnar joint, middle radioulnar joint, inferior radioulnar joint. Do you know what type of joint are they? Superior and inferior radioulnar joint, rotational movement takes place, supination and pronation, right? They are pivot joints. Supination, pronation itself is a short note question, right? The middle radioulnar joint connected by the introitious membrane, it is an example for syndesmosis, right? Now quickly, tell me what type of joints are they? Shoulder joint, ball and socket. Acromioclavicular joint, என்ன type of joint தெரியுமா? Plain synovial. Elbow joint, distal and the interphalangeal joints எல்லாமே வந்து hinge type of synovial joint. Wrist joint, metacarpophalangeal joint, neck, knuckle joints, they are example for ellipsoid. And one important short note, I don't know whether it was mentioned in the list, first carpometacarpal joint. The carpometacarpal joint of the thumb, that is an example of saddle type of synovial joint. Don't forget, okay? Very important. Yes, what is this? Name of the test. So you're trying to occlude the radial artery, ulnar artery. என்ன ஆகும்? ஹேண்டுக்கு blood supply இருக்காது. Pale ஆயிடும், right? And then you release one and see for the flow of the blood, flow pattern of the blood, right? Yeah. So this is called as the Allen test. இப்போ ரேடியல் ஆர்டரி எதுலயாவது அக்ளூஷன் இருந்துச்சு அப்படின்னா என்ன ஆகும்? அந்த இடத்துக்கு வந்து blood return ஆகுது. It will appear pale. Okay. It's called as the Allen test. And please remember the superficial and deep Palmarach, it can be tied as a spotter or it can be a short note question for you. So location, superficial Palmarach, it lies superficial to the long flexor tendons. Deep Palmarach, it lies deep to the long flexor tendons. Formation, superficial Palmarach is formed by, as you see here, the superficial branch of the ulnar artery that forms the major contribution for the superficial Palmarach, and it is terminated by, yes, either, yeah, the arteria princeps pollicis, arteria radialis indicis, superficial palmar branch of the radial artery, yes, and arteria nervi mediana. All these. The branches coming from the superficial palmar arch will include the palmar digital arteries. அதே மாதிரி deep palmar arch எடுத்துக்கிட்டோம்னா mainly the main continuation, the terminal part of the radial artery, anastomosis with the deep branch of the ulnar artery. இதோட branches will be the metacarpal, palmar metacarpal. This will be palmar digital arteries. Palmar metacarpal arteries and then perforating arteries. And then the recurrent branch. Okay, so you should be ready to write about a short note on superficial and deep palmar arch. Yes, this is another clinical important one. What you see here is the lower end of the radius. And as you see here, this is the scaphoid bone. One important thing about scaphoid bone is that it is a frequently fractured carpal bone. இது எங்க fracture ஆகும் அப்படின்னா, இதோட narrowest part which we call it as the waist of the scaphoid. Why is it important to know about the scaphoid bone, its fracture? Because it has a complication. இந்த scaphoid போனுக்கு blood supply வந்து எப்படி போகும் தெரியுமா? It comes from the distal to the proximal. பின்னாடி இருந்து முன்னாடி வருது. So இந்த இடத்துல fracture ஆகும்போது என்ன ஆகும்? எதுக்கு blood supply கட் ஆகுது? இதோட proximal பார்ட்டுக்கு. Okay, it undergoes avascular necrosis in its proximal part. Avascular necrosis of the scaphoid, it's called as Freeser's disease. Okay, we have learned in lower limb, right? Intracapsular fracture of neck of femur, avascular necrosis of head of femur. So fracture waist of scaphoid, the proximal part is devoid of blood supply. Yes, come on, waiting for your answers. The pointed structure is palmar aponeurosis. Its inflammatory condition is called Dupuytren's contracture. Oakman's ischemic contracture is the other name for compartment syndrome. What happens here? What condition it is seen? Supracondylar fracture of humerus pathon, injury to median nerve and brachial artery. So if the brachial artery is injured, then there is total loss of blood supply to the forearm muscles, isn't it? Yeah, the flexor compartment of the forearm supplied by the radial artery and ulnar artery. So all these muscles, they will not receive blood supply, ischemia, fibrosis, contracture. இதுக்கு பேர் என்ன? Inflammation of the pulp space. What is it called? Phelon or Whitlow? Inga, which part of the distal phalanx can undergo avascular necrosis? Proximal part or distal part? I'm giving you the option. Very good, Dr. Alia. Dupuytren's contracture is the right answer. Yes, in phelon, pulp. Yes, come on, give me the answer. So, facial spaces of palm, the mid-palmar space, the thenar space could be alone asked as a short note for you. The pulp space is also equally important, right? So here what you see, this is the distal phalanx, isn't it? And here, you can see the blood vessels coming here to supply the proximal 1/3, right? And over here, this is the septa. It is also an equal full-time job, but then this is the septa traversing the pulp space. The blood supply to the distal part, distal 2/3 of the distal phalanx, they have to travel through the septa and reach it. So when there's an infection in the pulp space, the blood supply to the distal 2/3 is compromised and that will undergo avascular necrosis. Got it? So, yeah. So what is pointed out here? You're able to identify the thenar and hypothenar muscles. This will be your abductor pollicis brevis. This is flexor pollicis brevis. And over here, this is again abductor digiti minimi, flexor digiti minimi. The lumbricals, okay, lumbricals வந்து pin பண்ணும்போது make sure you identify which lumbrical is it. The first, second, the third, and fourth. The one pointed out in this picture here is, yeah, the fourth lumbrical. So injury to the nerve supplying the pointed muscle will also result in paralysis of the fourth lumbrical is innervated by the ulnar nerve. Yes, what is the answer? Adductor pollicis. So, Najamave, the chocolate question, can you help with this one posture or like this thing. How do you test for median nerve, ulnar nerve, and radial nerve using this sign? Either anterior interosseous nerve injury can sono, median nerve is fine. If you feel for sensation in this area, இந்த இடத்துல நீங்க தொட்டீங்கன்னா இல்ல பின்ன வச்சு prick பண்ணீங்க அப்படின்னா, you're testing for superficial branch of radial nerve. Ulnar nerve எப்படி? How will you test for ulnar nerve in this area? What is the muscle present over here? Dorsum of the hand. This area we have the dorsal interossei, right? Paralysis of dorsal interossei in the இடத்துல என்ன ஆகும்? There'll be atrophy of that muscle. You can see a hollowing of that area. The only extension lost in posterior interosseous nerve syndrome is extension of the metacarpophalangeal joint. Okay, please remember the radial nerve, yeah, it has no action over shoulder joint, right? Yeah. Also the interphalangeal joint extension. Elbow extension, triceps. Wrist joint extension, all your extensor carpi radialis, longus, brevis, adellame, right? Metacarpophalangeal joint extension, yes, extensor digitorum, extensor indicis, digiti minimi, all that. Extension of the interphalangeal joint, we have learned that it's by the action of lumbricals innervated by ulnar nerve and median nerve. Okay, so radial nerve injury, you'll get to see wrist drop, not able to dorsiflex the wrist joint. You'll get to see thumb drop. Thumb extend பண்ண முடியாது, right? And finger drop. இதுல finger drop ன்னு சொல்றது metacarpophalangeal joint extension, not the interphalangeal joint extension. Okay. Nerves of upper limb ending in pseudoganglion we discussed, right? The nerve to teres minor, axillary nerve, and posterior interosseous nerve. Okay, so as we have discussed at the beginning of this session, please make yourselves thorough with all the essay questions, highly important previous year questions. And yes, all the short notes that have been listed, make yourselves thorough. Read it, try to recollect it, and try to write it also. And as I told you, essay question அப்படின்னா time management is important. 30 to 40 minutesல முடிச்சிடுங்க. ஒரு 3 pages ஆவது எழுதுங்க. நிறைய diagrams, anatomically correct diagrams கொடுங்க. Short notes கேட்டிருக்கும் போது try to write at least 1.5 pages. And every short note, make sure you draw a diagram and end it with applied anatomy. Okay, I think this session was useful for you to some extent. All the very best for your upper limb internal assessment. And thanks to Medusane team, thanks to Raghu for taking his time, yeah, for giving me this opportunity. Thank you, Raghu.
Thank you, ma'am. What an extraordinary session we had today with Dr. Rajkohila, ma'am. Her ability to break down the intricate concepts of anatomy and present it in such a shorter time and understandable way is truly unmatchable. She is without a doubt one of the medicine's star faculty, a constant source of knowledge and inspiration. Today's session, eye-yielding topic in the upper limb, attracted almost 350 to 400 students, and the number speaks the volume about her magnetic presence and teaching prowesses. That's the aura of Dr. Rajkohila, ma'am. Her power to draw students and keep them engaged with the eloquence and expertise is a hallmark of her greatness. Ma'am, you have been always a guiding light for medicine, and dedication to empower the medical students is nothing short of remarkable. Her sessions leave students not just informed but inspired, and today was no exception. A huge thank you to you, ma'am, for gracing with your expertise amidst various schedule you have, and for being such an integral part of medicine family. Wherever you go, whichever platform you take, Medicine will always be happy and always like keep on bothering you with asking for more sessions for the students. We look forward to many more insightful sessions with you, ma'am. And as you all know, ma'am is also taking now in DigiNow session, DigiNow platform, a unique startup by the JP publisher. You can also watch our videos from the app, which is having the almost the entire content of anatomy. Thank you, ma'am. Thank you so much. And we expect more such a torch bearing sessions from you, ma'am.
Thank you, Raghu. Thanks for the opportunity. And a kind request to all of you is like, do give your feedback. Like, I couldn't manage time to give for your lower limb. So we thought at least for upper limb, we'll give a session. So we have a lot more to cover in anatomy, right? So if you really find this session useful, we can also make up like in the future, a lot of sessions coming up. Do give your feedback, do reach us. Thank you. All the very best.
Thank you, ma'am. Ma'am, stream end பண்ணியாச்சு, ma'am.